Regional anesthesia. What is regional anesthesia? Regional anesthesia is a temporary reversible interruption of nerve transmission, and we can reverse this transmission at different levels of nervous system. This transmission is reversible, and the block lasts the time that the drug that is injected blocks the sodium channel. The regional anesthesia can be relatively short if we inject the drugs as a bolus, but when we use the catheter, we can give the drug as a continuous infusion. So in that term, the regional anesthesia can be really prolonged. When we say regional anesthesia, we talk about the treatment of pain that we perform during the operation. When we talk about post-operative analgesia, it means that we give the analgesics, local anesthetics, in the post-operative period. We use the same catheter implemented, let's say, in the epidural space, but intraoperatively, it's anesthesia. We use higher doses, higher concentration of a drug. Post-operatively, we use lower concentration of a drug, lower doses, because the analgesia, when there is no impulsation, doesn't have to be so strong as the treatment, pain treatment during operation, when the impulsation made by the surgeon is very strong. So the same catheter is used intraoperatively and postoperatively. Intraoperatively, lower doses is called higher doses. It's called anesthesia. Postoperatively, lower doses analgesia. And such postoperative analgesia using implemented catheter can last even for a few days. So this is the regional anesthesia, and later analgesia can be really long-lasting procedure. When we block the nerves, as I said, at different levels of the impulses at different levels of nervous system. So superficial is just very simple method of putting eye drops into the eye, on the eye. It's made by the surgeon during ophthalmologic surgery. This is, I think that some of you may have eye pain, may have some corneal lesion, and you in your past you used maybe ophthalmologic guts just to decrease the pain on the eye. So this is the superficial analgesia or anesthesia. Infiltration just infiltration is just putting infiltration. So you don't the person who performs infiltration regional anesthesia just inject local anesthetic around the wound. There is no need to look for any special nervous structure. Just blindly infiltrate the skin before incision or the skin before closure of intraoperatively. This is not very complicated, not complicated at all. Then we have something that where anesthesiologist task starts, because that superficial infiltration, it's really general. We perform peripheral blocks when we block plexuses or nerves. We perform central regional anesthesia when we stop the transfer of impulses at the spinal or epidural level. We inject the local anesthetic into the spinal or epidural space. There is something called beer block. It's intravenous regional anesthesia. I will show you the pictures later. It's possible to put intrapleural or catheter intrapleurally or intraperitoneally. It's usually done by thoracosurgeon, by general surgeon, because it's most cases done intraoperatively. And there can be also performed interfascial plane blocks. Plain blocks interfascial means that a local anesthetic are injected at the level of breast or at the level of between the muscles in the abdomen. The painful impulses travel from the nociceptor, then it's a receptor, then they go through the afferent nerve fibers to the nociceptive tracts, to the brain, to the brainstem, to the thalamus, and to the cortex. When the signal is changed into the information that we can and we know that there's pain. This impulse, the pain, normally causes the movement of a head, of a hand, of a body, which run away from the painful stimulus. When you hit the iron, hot iron, immediately we remove the hand. This is the full pain impulse way. One way is up to the brain, and then the second efferent is to our hand, and this is the signal, remove the hand. When there is a regional anesthesia, you will not feel, and the regionality of a hand, you will not feel the pain, so you will not remove the hand, and you can imagine what will happen. So the pain in some situation is a very necessary, very important feeling. Intraoperatively, this is not what we would like to feel, or we don't want our patient to feel, so we have to block the nerves. And now a few pictures. What kind of blocks can be performed? We do not perform all of them. Some of them are performed by the surgeon, like this one. This picture shows how to find out the nervous structure. So the nervous structure can be found by palpation of the vertebral column, by the bones. Palpation can use pulse, so pulsation of the arteries. It depends on the block. Which block we perform. So this is here the block will be performed, the block that will allow to decrease the pain in the neck and part of the head. So this is the superficial and deep cervical block. What is and it's done by surgeon who perform the operation in this region. Sometimes anesthesiologists can do that. In our hospital, it's made by a cardiovascular surgeon when they perform desobliteration of occluded atheromatic jugular vein, not vein but artery. This block of brachial plexus is made by anesthesiologists. The brachial plexus is a very big nervous structure located, we can say, in the region of the neck, clavicle, and axilla. And it can be blocked either at the level of the neck, either up, over, and or below the clavicle, or in the arm, in the axilla. Depending how high we block, the result of analgesia or anesthesia occurs. If the block is performed at the level neck, then the shoulder will be anesthetized and upper part of an arm. If it's done at the level of the clavicle, the shoulder will not be blocked, but the arm and almost all forearm and almost all hand. When it's done, when the block is performed in the axilla, only operation below the elbow can be performed. So it's an anatomical explanation because the nerves, fascicles change their position along the along the plexus. So depending when we inject the other local anesthetic, we have different effects. And here you can see that somebody is trying to anesthetize the plexus below the clavicle. Here is the place shown of needle incision over the clavicle. Here is in the axilla. On the first picture, nerve stimulator. This is the very simple nerve stimulator is used for identification of the plexus. So by inserting the needle connected to the stimulator and stimulating the nerve while the needle is pushed down, the operator is looking for the movements of a hand. If the movements are correct and satisfactory, then the local anesthetic, I mean correct, because depending which nerve you want to anesthetize, which part of the block, the reaction will be from the hand will be different. So if everything is fine, local anesthetic is injected, and within a few seconds, the stimulation decreases because there is no longer nerve signal transmission. Of course, the time for the whole block to be achieved takes more than a few seconds, but the first information that we successfully injected the local anesthetic can be observed very fast. Here you can also see that the person uses the stimulator as well on the last picture, but on the last picture we can also see that the hand is keeping the ultrasound. And this is the best way of identification of nervous technique, to use ultrasound to make visualization of the structure and the visualization of the injection of local anesthetic. Nerve stimulator plus ultrasonography is a very safe procedure, so the risk of injury of the nerve is low, very much decreased. The second, forearm can be also, the radial nerve can be blocked at the level of arm and musculocutaneous nerve. Some nerves can be blocked at the level of the elbow, and very simple block of the wrist. No ultrasound necessary. In fact, almost blindly, local anesthetic can be injected almost blindly around the wrist. So it's a circumferential block, we can say. And whole hand will be anesthetized. Very easy block, but not very pleasant. Easy for the person who is performing it, not very pleasant for the patient, because the injection of local anesthetic close to the bones is quite painful. It's like when you go to a dentist, it's not very pleasant, the injection of local anesthetic when it's injection just close to the bones. I'm sure that you know this feeling. So in the painful or unpleasant, it's good to give some small dose of opioids before intravenously, some low dose of sedation before performing a block, just to decrease the patient's discomfort, but not a deep sedation, just very, very light, or maybe just some opioid would be enough. Single fingers can be anesthetized by injection of local anesthetic at the level of each finger. This is something that this block and this block is usually done in an emergency department. It doesn't need special equipment, so everyone can do this. Beer block, intravenous regional anesthesia. This is something totally different from other regional techniques, because this is the only block when we inject local anesthetic into the vein. Or in all the other blocks, if you inject local anesthetic into the vessel, it will cause complications. It can cause very severe complications. complication, even cardiac arrest. So in the beer block, what first we have to do is we have to put two cuffs on the patient's arm, then use the elastic bandage to squeeze the hand and forearm and to remove the blood from the arm and from the hand and from the forearm. Then cuffs are inflated and local anesthetic is injected into this empty vein, and there is no risk that the intravenously injected anesthetic flushes to the circulation, because the vein and as well as artery are occluded by this cuff. So there is a ischemia, local ischemia of the arm, lower part of arm and forearm and the hand, and this ischemia can be kept for up to 2 hours. So surgeon commonly operate using ischemia, and in this, when we perform beer block, we use the same. So both anesthesiologist and surgeon are satisfied, because the ischemia is used for anesthetic injection and for the surgeon to decrease the bleeding. It's very important not to allow the cuff to be deflated 15-20 minutes before injection of anesthesia. 20 minutes is safe, 15, okay, maybe not very, but 20, because after 20 minutes, the local anesthetic has been injected into the vein. It's no longer in the vessel, it diffused into the tissue. So there is no risk of flushing the local anesthetic into the circulation in case of deflation of this cuff. So this is the most important fact in this beer block, is to keep the cuff inflated for 20 minutes after injection of anesthetic. Even if operation ends 5 minutes later, after injection, very short operation, you cannot deflate the cuff must be still inflated. If for such a short operation like 5 minutes, in fact, it doesn't make sense to do this anesthesia. In most cases, it's easy. It's better to perform short general anesthesia. But it can happen that operation, which was supposed to be longer, suddenly ended because it was very easy and prediction were different. So never deflate the cuff too early. We can perform several blocks at the level of a trunk. This is the picture showing the intercostal nerve blocks performed by injection of local anesthetic under the rib, between ribs, and the nerve and vessel lie under each rib. So the injection of anesthetic must be done close to the nerve, so just below the rib. What we can do also is we can do paravertebral block. It's an injection of local anesthetic 2.5 centimeters left or right to the vertebral column, and it allows us to achieve a partial block of the thorax. See, one side, left or right, depending when we inject the local anesthetic. Theoretically, it's possible to do it on both sides, but it's better not to do this because there is always risk of pneumothorax when we manipulate near the thorax, near the lungs. So if we do by mistake, by involuntary, one side pneumothorax, it's a problem, but the patient will still have second lung. If by hazard the pneumothorax will be bilaterally, then the patient has a very high risk of death, immediate death, or very short death. So it's a safety precaution not to perform it on the both sides, but it's not contraindicated, okay? But it's better not to do this. Thoracotomy, breast operation can be performed under this block. Then there are some blocks performed in the lower part of the body. This is the block that is done usually by the surgeon to decrease the pain in this level, lower part of abdomen for operation in the scrotum, for some urinary operation in children, urinary tract operation in children, mainly for scrotum operations and for inguinal hernia. This is done mostly by the surgeon who operates the patient. And we can do blocks in the lower limb by anesthetizing three. I didn't show it. To get the block of whole limb, we have to anesthetize three nerves. One is the femoral nerve, which is anesthetized in the inguinal region. Then there is a sciatic nerve, which lies between the gluteus muscles, so it's anesthetized at the level of the buttocks. And we have one nerve which has to be anesthetized in the medial part of the thigh. What it's possible to do is to inject, to perform the occlusion or the anesthesia of the three nerves by injecting local anesthetic in the at the level of psoas muscle. It's called psoas compartment, but this is not very common. Some nerves of lower limb can be also anesthetized below the thigh, so at the level of knee, and also the block of the foot. It can be done as an infiltration of the around the ankle. It's similar to the block that I showed you in a few minutes later. Wrist block, very simple, not comfortable for the patient, but very comfortable for us because there's no risk of injury, no risk of bleeding. What we also do is we perform spinal and epidural. These are called central blocks. It will come in a minute. How we identify the nerves? The first technique used years ago was a paresthesia technique. It means that you insert the needle and you wait or ask the patient whether the paresthesia can be felt or not. It's a paresthesia, it's a feeling like electricity passing through your hand, through your limb. I'm sure that you've once or twice in your life or even more hit your elbow against something hard. And then the pain, like something like electricity signal goes to the hand. So it's painful. It's short, but it's painful. But the paresthesia caused by the stimulation of the nerve lasts longer, it's not like one hit, it's just a little bit longer stimulation. So not very pleasant for the patient. And generally it should no longer be used right now. Blind paresthesia. We create the paresthesia by stimulation with nerve stimulator, but it's more under control than just a blind injection in blind insertion of the needle and looking for the paresthesia. Maybe I will touch the nerve, or maybe I will be close to the nerve. No, so I will try again. So it lasts. Paresthesia technique is a very unpleasant, and it should not be done without nerve stimulation. Based on the anatomical structure, as I said, we can palpate the bones, we can palpate the pulse, and we know that the nerve is behind the artery or below or over, under or over. So that's we identify the nerves. Electrostimulation with insulated needles. This is the techniques that uses nerve stimulator came started in 1955 and it's still used. And in 1978, ultrasonography was invented. The first technique of local anesthesia under the first movie on YouTube using this ultrasonography nerve block comes from 2005. And nowadays, ultrasonography plus electrostimulation is the basic methods of nerve techniques. What else we can use for the safety? Why do we use this ultrasound and nerve stimulation? One indication is with ultrasound to visualize the structure. With nerve, the second is to see how the injected local anesthetic spreads over the nerve, over the nerve structure, and the nerve stimulation we use also for identification of the nerve and as well as for being sure that we are not deep into the nerves, because depending on the current of the value of the electrical signal current, we know whether we are too close to the nerve or just we are in the nerve. So this is we shouldn't be within the nerve. So it's hand move, the limb movements, the muscle stimulation, muscles movement after the nerve stimulation, depending on the current, will tell us whether we are too close to the nerve or just in a good position. And the third method used to increase the safety of the block, regional block, is to use injection pressure monitoring. So with these three techniques, the safety is very high. So there can be some algorithm. No, that can be. There are some algorithms showing how to use this three monitoring technique. So the needle is connected to the stimulator. The signal is set. Needle is advanced toward the target nerve pulse. Everything is under the ultrasonography. So depending on the result, which is visible after the electricity current is turned on, we decide that we are fine, that we are in a good position or in a wrong position. So this is not very. It's we can have this algorithm before our eyes when we perform anesthesia, for instance, or we better should remember how to react depending on the motor response after the needle injection, or when there is no motor response, or when there's a poor image of anatomy. Depending, our attitude must change. So this is the injection pressure monitoring. It's a very simple method. A syringe with local anesthetic is connected to the needle, which is in the patient's tissue, and between the syringe and the catheter, this monitoring device is added. When there is when the needle is in the tissue, the pressure which is necessary to inject the local anesthetic is low. So you will see only the white or maybe the yellow color. If the pressure increases, is too high, then this element will go up and you will see the red. Red means it's wrong. The pressure increases when a needle is close to the nerve or within the nerve. And so even it's written what is the value of the pressure. So it's a very simple method and very effective. Spinal block and epidural block are something totally different from the block of the nerve or plexus, because we inject the local anesthetic not in the spinal, we inject it into the cerebrospinal fluid. In epidural, we inject into the epidural space. It can be the identification of the structure is done most cases by palpation of the vertebrae, so by using the anatomy technique, but however it can be also used under the ultrasound. No, nerve stimulation is not the method that we use that can be used for spinal or epidural. Only anatomy and ultrasound. Spinal anesthesia is very similar to lumbar puncture. In lumbar puncture, cerebrospinal fluid is drawn for the analysis of the spinal fluid in meningitis, for instance. In spinal anesthesia, we don't want to remove, we do not aspirate the spinal cerebrospinal fluid. We just inject local anesthetic into it. But what we would like to see after we put the needle into the spinal is a drop of cerebrospinal fluid. So we have to see that the cerebrospinal fluid wants to flow, but we do not wait until it really flushes. It's just, we have to see that we are in the spinal, and we can see it by seeing the one drop of cerebrospinal fluid coming from the needle. No fluid, no block. It's said like that. Block, there is after injection of local anesthetic into the spinal, small volume, maximum 4 milliliters in non-pregnant person. In pregnant, it's less than 4 milliliters of local anesthetic, so very small amount, and it will give us the block with stable extent and duration for, depending on the drug. Usually we use spinal heavy bupivacaine. It lasts for sometimes 4 hours. And the block, this is what you have to see when you inject the needle. 1-2 drops of, one is enough, in fact, of cerebrospinal fluid. We inject the local anesthetic below the lumbar 3 vertebrae. In most patients, in a few months, the nervous, I forgot the name. This basic nervous structure ends at the level of vertebrae L3, so it's safe. There are only lower. There are only some final nerves. They run away from the needle when the needle is inserted, so there is no risk that we inject the local anesthetic, that we advance the needle into the nervous structure. So safety precautions is to perform spinal below the L3. This is how it can be done. Generally, it should be covered by the clean drap or foil drap below this level, and this is just to show you how the patient's vertebral column can look like. And this is the level 4 here, and it's a little bit over it, so it's before L3 and L4. Spinal block starts very rapidly. Within seconds, the patient will tell you that he feels warm in the buttocks. It's the result of block of sympathetic fibers. When the sympathetic fibers are blocked, vessels dilate, and when the vessels dilate, perfusion of the blood increases, and it's felt like a warm feeling. Then the patient within minutes will, generally the block starts immediately, and 3, 4, 5 minutes it's full. So the decrease of sensation is very fast. The patient will start feeling cold, then the needle, the pain, the slight pain, then more intense pain, then the tactile sensation disappear, deep sensation disappear, ability to move the limb disappears, and vibration and proprioceptive sensation disappears as the last. And sometimes, in most cases, the spinal is full and deep. Sometimes it's the motion can be and feeling of deep, the feeling of vibration, of proprioception can be not blocked. So that is not the problem. The most important thing is to decrease, is to give the patient analgesia. So even if the patient can move a little bit with the limb, as long as it's not a problem for the surgeon, no, it's not a problem at all. Spinal block has an influence to the whole body. Local anesthesia, the nerve, when we inject the local anesthetic to the plexus or to the nerve, we only turn off the pain and the movement, but there is no influence of regional block on the whole body. When we do spinal and epidural, this influence is much more pronounced. It's totally different compared to the nerve block. Because when we inject the spinal, we turn off the sympathetic impulsation. So as I said, dilation of vessel occludes, as well as sympathetic. If we do quite high spinal, high spinal means that it can extend from the patient's foot till to the sternum. Sometimes it's even higher, but then it's too high. But when the block is as high as to the sternum, it's good for the cesarean section. For most operation in the lower part of the body, it's enough to block the nerves to the T10, thoracic level of vertebrae 10. It's the middle of the abdomen. The block causes the hypotension, and the spinal, if it's too high, can cause decreased impulsation to cardiac nerve, to nerve accelerantes, so bradycardia may occur. The block starts rapidly, but the full stabilization needs 20 or even 40 minutes. What does it mean? It means that for 40 minutes, we shouldn't move the patient. The position of the patient head should be relatively stable. The risk of bradycardia is higher in healthy ASA1 patients, young patients below 50 years old, and those who take drugs that block heart-rate beta blockers. How can we prevent the hypotension? Theoretically, we could influence up to 1 liter of crystalloid before we perform the block. It's called preload, but it has been shown that there is no effect. So it's better to give fluids, a little bit of fluids, not too much, when we perform the block, not before, but when we perform the block, and to give at the same moment the drug that causes vasoconstriction. Phenylephrine, ephedrine, these are the drugs that causes the vessels to constrict. Only when we know that during the operation for sure there will be bleeding, then it's good to supplement of fluids early. It's called early means when at the moment when we perform the block. not before, but when we perform, and we give more fluids when we know that there will be blood of loss intraoperatively in cesarean section. In cesarean section, up to 1 liter of blood can be lost. If it's more than 1 liter, we call it hemorrhage, but the 1 liter, it's kind of not physiological, but acceptable blood loss. If the hypotension is only mild, it's not a very big problem. When the blood pressure is a little bit lower than normally, the bleeding is decreased, so it's mild hypotension can be accepted because it's usually well tolerated by the patients. Spinal, if it's normal, low spinal, it does not influence on breathing. If it's higher, then if it's higher at the level of the thorax, then it can decrease the function. It decreases the function of intercostal muscles, which are muscle used when we breathe. So the patient may feel a dyspnea, may not be able to take a deep breath, may have difficulties with coughing, some cardiac problems may occur, but as long as the patient is able to talk, it's not a problem. When the block is too high, it's called total spinal. It's a complication, potentially lethal complication of spinal when the local anesthetic spreads up to the cervical level. Apnea will occur because the impulsation to the diaphragm will be blocked. And without the diaphragm, it's hard to breathe. So the patient will be apneic. All the rest of the respiratory muscle will be also blocked because they are innervated by the thoracic nerves. So everything below C3 is blocked. So the patient will be apneic. This is the very severe, very uncommon but possible complication. High total spinal. The spinal block increases the peristalsis. Intestines collapse, but peristalsis is increased. It's a result of impulsation of vagal nerve. When we perform local anesthesia, we have to have IV access, a breathing system, so the possibility to ventilate the patients, laryngoscope, blades, tubes, equipment that's needed for intubation. We have to monitor vital function. We need suction device. We need normally working operation table. We have to have kit and drugs for resuscitation and fluid for infusion. So in fact, it doesn't matter whether a patient must have empty stomach, so that there cannot be full stomach. So the precautions made before local anesthesia, regional blocks, spinal blocks, is the same as for general anesthesia. We cannot say that regional block is something less important. It is not less important, and complication can occur. So the block that is the second central block is an epidural. And epidural block means that we inject the local anesthetic, and in most cases, we implement a catheter into the epidural space, which is one step more peripherally compared to the spinal. Anatomy, I'm sure that you've had anatomy on, so you know what is epidural space. And the epidural space is located everywhere from the cervical to the lumbar and sacral region. So epidural block can be done at the cervical, thoracic, lumbar, and sacral level. It's very seldom done at the cervical level because there is always risk of injecting local anesthetic into the spinal. So if we inject it by the mistake, if we go a little bit too deep and to inject the local anesthetic in the spinal fluid at the cervical level, apnea will be immediately. So this we will cause the patient stop breathing. So it's possible, but it's very, very seldom performed. We've never done it in our hospital. Maybe somewhere, but rather it doesn't make sense to make it at this dangerous level. So epidural is done at the thoracic level for thorax operation, for lung operation, for operation of the upper part of the abdomen, like pancreatic operations. And it can be done at the lumbar level for abdominal operation, for operation of the lower limb. In sacral, in adult, it's not done because this, the sacral bone cannot be, the sacral bone is a bone, so there is no way we can put a needle through this bone. And in children, using the sacral hiatus, the block is done. Spinal block only at this level when there is safely. Epidural theoretically at every level of the vertebral column. Epidural means that you inject local anesthetic or put the catheter in the epidural space, which contains also vessels, vein vessels. So we have to be sure that we accidentally do not inject local anesthetic into the blood. We have to aspirate, we have to control it. So you can see on this picture where there is epidural and spinal is deeper. So if when performing epidural we go too deep, then we may perform accidentally spinal. It's not a good thing to do it because with epidural we use high doses of local anesthetic. In spinal we use small doses. So if we inject, if we go too deep and we will be thinking that we are still in epidural, and in fact we will be deeper in the spinal, and we inject this 8-10 milliliters, then there will be a very, very profound spinal anesthesia. Total spinal is possible. So precautions must be made not to do this. These precautions you will be told maybe later in the next 2 years when we will come to the practical classes. The main difference between spinal and epidural is different location of local anesthetic, and in clinical scenario, spinal starts very rapidly, almost immediately, and the full spread is within minutes, and epidural starts slower. It's necessary to wait 25 minutes for this full effect of this block. So with spinal, operation can be started immediately. With epidural, no, because the patient will be still feeling pain. Generally, in most cases, when we use epidural as an additive to the general anesthesia. So epidural is used for the anesthesia control of the pain, and the general anesthesia is used for to anesthetize the patient. So spinal can be done without, and is done mostly without general anesthesia additional. Epidural in most cases is concomitant with general anesthesia. Epidural also has, similarly to spinal, has effect on the whole organism, but these effects are not so pronounced. So hypotension will not be so profound and not so fast compared to the spinal, because the sympathetic blocks needs 25-26 minutes to be achieved. So the vessels dilate very slowly, not so suddenly like in a spinal. This is the indirect effect of spinal, and then can be also a direct effect of epidural on circulation when the local anesthetic is being absorbed into the blood, and then the heart changes in heart rate may occur, but this is rather not very common. Epidural influences on respiration. If it's low, similar to the spinal, lumbar and low thoracic, respiration is not changed. If it's some patients previously with some breathing problems, some compromised patients with low thoracic may feel some maybe not difficulties, but some changes in the breathing pattern, in taking the breath, but generally it's not very important. If it's high, then it's concerned, then it means that also abdominal and intercostal muscles are paralyzed, active in exhalation is impaired. If it's high thoracic, the patient may feel dyspnea, cannot feel, may not feel the movement of the chest. But as long as the patient is able to speak, it means that the breathing is still fine. So this is only the feeling of dyspnea, not a very complicated, not a real problem. And when the patient is not able to speak, because it means that the respiration is not effective, and then we have to intubate the patient. Similarly to the spinal flow through the kidneys from the liver is decreased in epidural. There is an atonia of urinary bladder. It's a normal. Intestines increased peristalsis, increased excretion. Catecholamine are blocked, and thermoregulation is changed. With spinal epidural, the vessels cannot constrict, so the loss of temperature is very high. We have to remember it. Spinal is an extent block, so thermoregulation in the lower part of the body is totally turned off. So the patient's spinal has to be kept in a warm, if possible, in a warm. Should be covered with something warm, but it's not always possible if the operation is. Depending on the extent of the operation, we can use some blankets or not. With epidural, if the epidural is extended, then the thermoregulation will be also not effective. Epidural, depending on the dose that we use for epidural, we can create the block that extends from the top, from the feet to the abdomen or to the thorax, or we can just perform the we can just give not so much local anesthetic, and then the analgesia the block will be only at the level of several dermatomes. So it's possible that the epidural, the epidural will be only at the thoracic level. So we can then, it's possible to create different extents of epidural. With spinal, it's always on the lower part of the body. Depending on the dose, it can be to the knee or to the thigh or higher. But it's not so easy to perform it only in a part of the body. Epidural is fine. This is the patient. In epidural, it's possible that the block is only at that level or at this thoracic level. Here you have the patient with epidural catheter implemented, and this epidural catheter will be used for the operation and post-operatively. Spinal is a single shot. Epidural can be single shot, but it's not does not make sense. In epidural, we do the shot infusion of we inject the local anesthetic and we put the catheter. So the first effect will be within 25 minutes, and then during the operation and post-operatively, we use the catheter for infusion of local anesthetic. I told you that also epidural can be done in the sacral region. So in this hiatus, sacral hiatus in children. In adults, it's occluded. There's a bone here, so it's impossible to inject a catheter. In children, you can either inject one single dose of local anesthetic, or you can implement a catheter through this hole, through this foramen, and this catheter can be put very high, even for operation within the chest. What can also be done is a combined spinal and epidural. This is something that gives us the immediate effect after the injection into the spinal, and then the catheter is put into the epidural, and the block can be used continuously for a longer period of time. When do we use this combined spinal and epidural? In labor. Women who are in labor, they feel pain. So it's good to decrease this pain relatively fast. So using either one needle through the needle technique, or we can put separate needles. So two needles will be used one by one. We can use this block. So first you put a needle into the epidural space. If you have this set, then through this needle you put a needle another one which should go into the spinal. The anesthetic is injected here into the spinal, and the pain decreases immediately. And then this needle is removed. The catheter is being put through the epidural needle, and the needle is removed. Catheter stays in place, and through this catheter, the local anesthetic can be given for the whole labor for several hours. It doesn't matter how much. If suddenly the woman needs to be operated, it's enough. It's good. We inject higher dose of local anesthetic into the catheter, and the patient may be operated under the same anesthesia. There's no need to perform general anesthesia and any other anesthesia, because we already have a catheter, and we just give higher dose of local anesthetic to decrease more intense pain compared to the labor pain. This picture is in Polish. Sorry, this is not an algorithm, but this picture shows that there are 5 clue elements which without them together they have to be performed one by one or concomitantly. If one drops, there will be no effect of positive effect of local anesthesia. So first, the patient must be educated preoperatively by anesthesiologist, by the surgeon, and the patient must be correctly chosen, cooperative patient. Then anesthesiologist performs the technique, the block with proper technique, with some premedication, some sedation, proper choose, the good choice of the local anesthetic must be done precisely, and the equipment must be correct. Then there is perioperative period and post-operative period. Nurses are mainly here when its block is performed. An anesthetic nurse helps to perform this block. Post-operatively, in general wards, these are nurses who change the syringes with local anesthetic if there is a catheter. So without them, the pain treatment post-operatively will not be successful. So they have to take care of the patients post-operatively. Regional anesthesia after regional anesthesia, patient must feel better, not only the doctor. What does it mean? It means that we have to be sure that we decrease the pain. We cannot say, okay, you shouldn't feel the pain, you have a catheter, if you feel something, it's impossible. No, something might have happened with the catheter, this dislocation, occlusion of the catheter. If the patient tells you that he or she feels pain despite having a catheter in place, it means that something is happening. Either these technical problems or there is a hematoma being occurring, or the catheter migrated and touches the nerve, we have to check why it's pain. Of course, it's possible that the patient receives too low dose of analgesia, or the patient did not receive the dose because the nurses forgot, so she did something else, forgot about the patient. Postoperative is possible. So we always have to prescribe some IV analgesics as a rescue, because the diagnosis of lack of effect must be done, but at the same moment we have to give something to patients to decrease the pain. So rescue analgesics. What are the contraindications for local blocks? Patient refusal, infection at the site, or true local anesthetic toxicity. Relative coagulopathy, coexisting non-diagnosed neurologic deficit. This is in many cases medical legal. So if the patient who has some chronic pain accept that we manipulate at this region, it's fine. But it must be everything explained, signed in the documents. Risk factors for complications: the previous neurological deficit, pre-existing neuropathy, commonly diabetic neuropathy, and coagulopathy. There's a risk of hematoma. For deep blocks, when the hematoma may have important meaning, we have to be sure that ENR, this is the parameters that shows us that the coagulation is not, some part of coagulation is fine, must be normal, and the last dose of low molecular weight heparin must be cannot be given within 12 hours. So 12 hours must have been passed before the last dose of heparin, a low molecular weight heparin, and and then we can perform deep blocks. With a superficial, it's not such a problem. Patient must know that what are the risks. Patient should know how the procedure looks like, because those local blocks are performed in a conscious patient. So the patient must be cooperative and should know what will happen during the procedure, which sometimes lasts 20 hours, 20 minutes, or the preparation and the performance of the block may take long. If you have to anesthetize 3 nerves of a lower limb, it may take a few minutes. The patient must know that block may not be effective, that then there would be a possibility of general anesthesia. There's a risk of infection, that the block will last for a few hours after the operation, that there might be feeling of paresthesia when the blocks disappears, that there will be a motor block, the patient will not be able to move the hand for a few hours, that there is a risk of nerve damage. However, permanent is extremely rare. Usually if something is damaged, it will get better, but in some situations it requires weeks and months, but this is really very rare. And there is a risk of local anesthetic toxicity. Advantages of regional anesthesia is that we can avoid general anesthetics and its side effects. Usually post-operatively, the quality of analgesia is better. There is no need to use opioids, so there will be no nausea, no vomiting, no peristalsis, block of peristalsis. The patient will be able to go home earlier, and it's possible to use a continuous block. There are the complications of blocks and catheters is local inflammation, local infection, abscesses, extremely rare is sepsis, and bacterial colonization is possible. And the risks of infection is increased when the patient is intensive care, when it's a traumatic patient. If it's a patient with some immunological problems, most common is diabetes. If the catheters are more than 2 days, in male patients and if there is no antibiotic prophylaxis given to the patient preoperatively. When I told you that we cannot inject the local anesthetic into the nerve, so here on the pictures you see what happens when we advance the needle. Intramuscular injection will not be very effective. This is not the place where we should inject the local anesthetic. No, there will be no effect of local anesthesia. Then what we have to go deeper. We should, in our needle, should go in the perineural space around the nerve, within the nerve, but not in the fascicles. Yes, this is the good place for the position of local anesthetic. Too deep against the epineuron, it will cause the damage to the nerve. So it's too deep. Intraneural injection, maybe one day will be acceptable. For right now, it's not acceptable. Intrafascicular injection will do the permanent terrible damage to the nerve. It's the worst possibility. So in fact, we see that the distance for the needle is very small. Not here, not here, here, between. That's why it's extremely important to perform local blocks using good visualization or monitoring methods. So nerve stimulation and ultrasound. Nerve damage. Depending where we perform this block, the risk of neurologic symptoms is different. Usually nerve damage is sensory and usually temporary. However, it may last for 1 month. Other causes of nerve damage after the local anesthesia procedures can be other than just our treatment, our injection. So by having this tourniquet, by immobilization of the hand, inappropriate position of the limb, nerve compression, too much extension, surgical equipment, it can cause also nerve damage, not only anesthetic performance. And we have to be sure that it's important when when the person sees a doctor, anesthesiologist for nerve damage. It has to be kept in mind that other possibilities of nerve damage are also possible. When the motor deficit or evolving block is in disproportion to the block that we wanted to perform, or is totally complete, it means that there is a red flag, something wrong is happening. What you have to know is the complication of the local anesthesia injection is a local anesthetic systemic toxicity. It's called LAST. Usually, LAST happens when we give too high dose of local anesthetic. Every local anesthetic has its maximal dose, and every block has the maximal dose. So for the block here around the wrist, we use small doses of local anesthetic. For the brachial plexus, we have to give much more of anesthetics because the plexus is much higher compared to the small nerves here. So the dose, maximal dose for this block will be different from that block. And plus there is a total maximal dose of local anesthetic that can be given to the patient. So the dose that we use here cannot exceed the maximal safe dose of local anesthetic. So the other risk, if the dose are exceeding the maximal doses, the toxicity may occur, and the toxicity will occur if we, by mistake, inject the local anesthetic just intravascularly, because then the concentration of local anesthetic in the vessels will be high immediately. And what we will see will be the central nervous system signs and cardiovascular system toxicity. Why? Because the nervous system and conductive heart system are these are the nervous part of nervous system, nervous system structures. So the block of the sodium channels will occur then. The block that is used, that happens at the level of the nerve, will happen at the level of conduction in the central nervous system and in conduction system within the heart. So everywhere there are the conduction systems. ON means brain. Acidosis, hypercardia, hypoxemia, increased toxicity. So local anesthetic toxicity from the nervous system will start with excitation and then will be depression. Without central nervous system, when toxicity will happen? When the patient will be under general anesthesia. So because nervous toxicity is pricking sensation in mouth, metallic taste, tinnitus, vertigo, problem with speaking, muscle contractions, loss of consciousness, seizures, coma, and apnea. If the patient is already under the general anesthesia and during the general anesthesia, this toxicity occurs, all this will not be able to be seen because the patient is anesthetized. Patient is already in anesthetic coma and is not breathing because then is paralyzed, muscles are paralyzed. So we will not see even muscle contractions, nothing. So the first, if the patient is anesthetized, what we will see will be cardiac depression, dysrhythmias, cardiac arrest. If the patient is conscious, not anesthetized, then the patient will tell you that something happens, something strange happens. What we have to do is, if we are still injecting the local anesthetic, we have to stop it immediately. If metallic sensation starts, it doesn't happen. It doesn't mean that every steps will happen, that the patient will have apnea and cardiac arrest. It's possible that the concentration of local anesthetic will not be as high that it will cause cardiovascular toxicity. Maybe it will be low and just the loss of consciousness will occur. No seizures, no coma, no apnea. But if the concentration increases, then the more local anesthetic is in the blood, the more pronounced the toxicity is, and cardiac depression starts at the higher level of local anesthetics in the concentration compared to the neurotoxicity. How to prevent this? We prevent toxicity by choosing local anesthetic with the safest profile. The safest profile for the block. For instance, when we have to give high doses, it's better to choose something safe, some safe drug. The most dangerous one is bupivacaine, because bupivacaine has a high affinity to the conductive heart system. It's very cardiotoxic. And bupivacaine is used commonly in local anesthesia. But when the high doses are necessary, then it's better to choose some safer drugs like ropivacaine or levobupivacaine, which have the time and the strength of similar to bupivacaine, but cardiac toxicity is lower. After the change of needle position and before the bolus given into the catheter, we have to aspirate. However, if the needle is within the vessel, with the aspiration, we should see the blood being aspirated. However, it's not 100% sure because the wall vessel can occlude the needle tip, and the aspiration will not be effective. So we cannot be 100% sure that when we aspirate and there is no blood, that we are not in a vessel. By using test dose of local anesthetic mixed with epinephrine before each block, we can be sure that if within 1-2 minutes heart rate increases, probably we are in the vessel, because the small dose of local anesthetic will not cause this small dose injected into the vein and will not cause the toxicity, but epinephrine injected concomitantly will increase, the small dose of epinephrine will increase the heart rate. So increase the heart rate is it means that we are in where we shouldn't be, so in a vessel. However, in some blocks, epinephrine is contraindicated when we inject the local anesthetic near the final vessels. Ear, fingers, and penis are, we cannot use the epinephrine. Aspiration, continuous observation of the patient, slow injection without exceeding the pressure on the syringe, and we have to just prevent correct dosing. So I told you that the local anesthetic have maximal doses, and this maximal doses is 2 milliliters per kilo for bupivacaine, 3 milliliters per kilo for ropivacaine, 3 milligrams per kilo for lidocaine. If lidocaine is mixed with adrenaline, then the dose can be increased to 7. However, with bupivacaine, it doesn't matter whether you mix it with adrenaline or not, still 2 milligrams per kilo, because the bupivacaine is the most toxic one. The checklist for the treatment of local anesthetic toxicity is something that we have to follow. So reduce, if cardiac arrest happens, we have to perform CPR. The doses of epinephrine are smaller than in a normal, let's say normal, cardiac arrest caused by other reasons. We should avoid some drugs. We have to stop injection anesthetic, get help. Ventilate the patient. We have to control seizures by giving benzodiazepine, some small doses of propofol. We have to treat hypotension, bradycardia. If it's pulseless, then start CPR with small doses of epinephrine. The treatment that has to be done in last reaction is to give the patient lipid emulsion. Emulsion to 20% intralipid. It's an emulsion used normally for parenteral nutrition. It's a fatty emulsion, lipid emulsion. So in parenteral nutrition, we use it as a source of lipids. It has been found that it decreases that it shortens the time from cardiac arrest to regaining of spontaneous circulation in cardiac arrest caused by local anesthetic. So it's obligatory to use this emulsion when patient becomes cardiovascularly unstable. We don't have to use it when the patient feels the metallic taste, but if the symptoms become more serious, we don't wait for cardiac arrest. If cardiac arrest happens, then it will shorten the time of cardiac arrest, which can still be for 1 hour or even more, the cardiac arrest, but it can also prevent from cardiac arrest. The precise volume flow rate are not crucial. It's just to show us how much we should use. Generally, 12 milliliters per kilo is the maximum dose, and the average volume, it's less than 1 liter, around 1 liter, 700, 800 milliliters for an average person. We should continue monitoring few hours after the cardiovascular effect of problems, or if it was only central nervous system toxicity, 2 hour minimum, for minimum than 2 hours. And this system, this checklist should be available everywhere, and low lipid emulsion everywhere when local anesthesia is being performed. This local anesthetic toxicity will not happen after the spinal because there are no vessels in which we can inject the drug, but each other regional block can happen in each regional block. The highest risk is for intercostal block, because it's very easy to inject the local anesthetic into this vessel, and there is a small space when we inject this local anesthetic under the rib, so it's very easy. The risk of absorption is high, and risk of injection into the vessel is also high. This is the same, in fact. So what are the local anesthetics positives? They prevent and treat pain. They act, if no complication, they act only at injection site. If we perform regional block, if we perform spinal epidural, they have also general effects. Yes? It's like hypotension, for instance. The effect decreases with time, because the local anesthetic, which is injected to the tissue, to the epineuron, is to the nervous structure, is absorbed by the blood. When it's absorbed into the blood, then the concentration at the nerves or tissue decreases, and the concentration within the nerve decreases. So normally they block sodium channel. If the concentration is lower and lower and lower, they diffuse from the sodium channel, and the sodium channel can act normally, and the sodium channels are necessary for the nerve impulses. Unblocking of sodium channels allows the nervous system to work normally again. They may cause general effects, which can be intended. We use lidocaine intravenously, but not as a part of local anesthesia. We use lidocaine as a treatment of generalized pain. This is not the topic of today. We use also lidocaine as an antiarrhythmic drug in cardiac arrest. So small doses of lidocaine can be given intravenously intended, but when we talk about the regional block, intravenous or intravascular injection is incorrect. So we have to divide two indication for lidocaine. So intended stabilization of the heart and pain treatment when we give lidocaine IV, or not intended toxic or allergic reaction. The effect of local anesthetic is caused by decreasing the function of the nerve. Normally, there is a transmembrane electric potential within through the nervous membrane is created by sodium-potassium pump. Normally, there's a continuous outflow of potassium from the cells to outside, and the negative charge is intracellularly, and when the impulse comes from the nervous system, there is a depolarization signal. If the depolarization means opening of sodium channels is enough, all or nothing, then the impulse passes and the nervous system, we squeeze the hand, for instance, so there is a signal to the muscle. Then it's a repolarization when the nerve is not responding to the signal, and resting potential comes back. And local anesthetic injected into the tissue has to block sodium channel. This is the nerve, this is the tissue. Unfortunately, when we inject the local anesthetic into the tissue, it cannot just go free easily into the nerve, into the cell. It has to become, we inject your ionized form, cation form. This form is in a syringe, in a bottle. In the tissue, it has to be changed into the non-ionized form, neutral, which is soluble in lipids. Then, because it's soluble in lipids, it can pass through the cellular membrane into the cell, nervous cell. Within within the cells, it has to again become ionized, and only the ionized form can occlude, can close the sodium channel. It would be much easier if this form could pass, this ionized form could just pass into the cell, but it doesn't happen. So these changes, chemical changes may occur. All penetration is necessary. Only very small of injected local anesthetic penetrates into the nerves. And for a given anesthetic, for a total block, minimal concentration must be achieved to occlude, to decrease this stimulation. So when time passes, less, as I told you, that the local anesthetic is, the concentration of local anesthetic within the tissue decreases. So local anesthetic goes opposite way from the cell outside the cell. It's removed by the blood, so continuously from the cell to the tissue, to the tissue, to the tissue. The concentration within the cell decreases, and it diffuses it from the channel. The channel becomes open, and the signal can be performed again. And we have several types, two main groups of local anesthetic. One group is called amide local anesthetic, and the other are ester anesthetics, depending on the chain, intermediate chain between the aromatic group and amine group. And the characteristic is different depending whether it's ester or amides. Esters are metabolized by enzymes, by esterase within the blood. They are unstable. They have short storage time, as well as short blocking function, short time of a block. Because they are very fast metabolized. So the toxicity is the risk of toxicity is low, because there is no time for them to be in such concentration that it causes toxicity. Amides, on the other hand, are stable. They are metabolized by the liver, and they can accumulate if liver is not functioning, and the toxicity is more often. But anaphylaxis, allergic reactions are, in contrast, lower. The risk of anaphylaxis, allergic reactions with amides is lower compared to allergic reactions after the